Hi guys, so I'm going to go over the articulations in this video. So an articulation is just the place of contact between bones and cartilage, or between bones and teeth. For our purposes, it's mostly just going to be between bones. And I just want to point out that as a joint becomes more mobile, it becomes less stable. So your glenohumeral joint, remember, head of humerus articulates with the glenoid fossa of the scapula. It's going to be a ball and socket joint. So it's our most mobile joint. You can do a wide range of actions at this joint, but it's going to be the least stable. All right. And so as you become more stable, you become less mobile. All right, so our first functional classification of a joint is called a synarthrosis. And I always like to say that it would be a sin for these joints to move. So they're immobile joints. And the first example here is a suture. Remember, a suture is just a point of articulation between our cranial bones. So we have the coronal suture, the sagittal suture, the lambdoid suture back here, and then we have our squamous suture on the lateral aspect of our skull. And so we definitely do not want our cranial bones moving. I think that would be very bad. So that's going to be a synarthrosis. And then another one I just threw in here, you don't really need to know it. It's a gomphosis, and that's just going to be the joint that holds your tooth into your jaw. So you have these periodontal membranes here that hold the tooth into the alveolar process of both your mandible, and then the same principle applies to your maxilla for your upper teeth. Our next functional classification of a joint is an amphiarthrosis. And so as the prefix amphi implies, you're just going to have a little bit of mobility. So it's a slightly mobile joint reinforced by ligaments. And so the kind of amphiarthrosis that we looked at was called a symphysis. So a symphysis is just a joint that has fibrocartilage between the bones. And so the first one that we saw was the pubic symphysis. So that's going to be the articulation between the pubis of the right os coxae with the pubis of the left os coxae here. And so right here is a pad of fibrocartilage. And the reason why we would want this joint to be slightly mobile, especially for women, is if you're pregnant and you're holding a fetus, you definitely want the pelvic cavity to be able to expand just a little bit, especially once you are ready to give birth. And then the second amphiarthrosis that we looked at was the intervertebral disc articulation. So we're not talking about the articular facets right now, just the discs. So here's the intervertebral disc. Remember, it's composed of the outer layer, the annulus fibrosus of fibrocartilage, and then the inner nucleus pulposus. So here, when you flex your spine, you're actually going to have little movements, and the intervertebral disc, if you're flexing anteriorly, the disc will just bulge out just a little bit posteriorly. And then when you're extending your spine, the disc will just move a little bit anteriorly to allow your spine to flex as a whole. So it's the culmination of these teeny tiny movements that really allow the full motion. All right, so now we're going to move into the diarthroses, or your synovial joints. So these are going to be your freely mobile joints. So all of the joints that you probably think of. So your shoulder joint, your elbow joint, your wrist joint, your knee joint, all of them. So it's going to be a fluid-filled joint cavity, and that's going to be surrounding the bones. The bones will be covered with articular cartilage, all held within this synovial joint cavity, filled with synovial fluid. And so, as we'll see, the bones are joined by ligaments. So here's the general anatomy of a diarthrotic joint. So let's start with the bones. Remember, the bones are going to be covered with hyaline cartilage, right? And so since these bones are articulating, we're just going to call it articular cartilage. But remember, it is hyaline cartilage. And so now we can see, we'll look into the capsule. So the articular/joint capsule, it's a double layered capsule that composes a synovial joint. So the outer layer here, it's this fibrous layer, and that's formed from dense connective tissue. And then we have this inner layer, it's in purple in this picture. That's going to be your synovial membrane. So the synovial membrane is going to be secreting synovial fluid. Synovial fluid is just this really slippery, oily lubricant, and that's going to be preventing friction. It's going to allow these bones to move smoothly against one another as well. So the joint cavity then is going to be that space created by the synovial membrane. And so it's going to be filled with synovial fluid. So it's going to be really slippery and oily within here. So what's contained within the joint cavity? The bones, the articular cartilage. And now everything else that we're going to talk about on this slide is going to be outside the joint cavity. Definitely something that you need to understand. So ligaments, dense regular connective tissue connecting bone to bone. So here in white is the ligament, and this is the fibrous layer of the capsule. So as you can see, this ligament connecting these two bones, it's outside of the joint cavity. Ligaments are poorly vascularized, so they do take a long time to heal following injury. It's something to point out. And then same thing goes for tendons, also dense regular connective tissue, but instead of attaching bone to bone, they will attach a muscle to a bone. And we don't have a muscle in this picture, but again, it would be outside of this joint cavity here. Fat pads are going to be distributed also outside of the joint cavity, as you can see in this image on the bottom right. None of them are inside the joint cavity. So the fat pads outside the cavity, they serve to insulate the joint and just to cushion it and add some extra protection as well. And now we're going to look at this last one here, a bursa. So a bursa, it's pretty much like a little water balloon, like a little sac, and it itself is composed of a synovial membrane, which is going to be secreting synovial fluid right within the bursa. And so the bursa, again, outside of the joint cavity, they're just going to occur around the joint and to, again, prevent friction, also preventing friction between the ligaments, and just to add some extra protection there. So as you can see, we have 4 bursae in this picture, and they're all outside of the joint cavity, and you don't need to worry about the tendon sheath. So now we're going to move into our types of diarthrotic joints. So the first one, the gliding joint, this one has the least amount of movement, meaning it's the most stable. So it's uniaxial, and it only allows just little teeny tiny side to side movement. So our articular surfaces of bones are flat or planar, and we can see this in the intercarpal and the intertarsal joints. So anytime that you have action at the wrist, any movement at the wrist, your carpals are just going to barely slide past one another, just a teeny bit of sliding action. And the same applies for the intertarsal joint. So your tarsal bones will just barely slide past one another and allow that smooth movement to occur. Your temporomandibular joint, it's a combination of a gliding joint and a hinge joint. So that's me gliding my mandible right now. Also, side to side, that's a gliding joint right there. I'll come back to that though in a few slides. And then finally, our zygoapophyseal joint. So this is the articulation between inferior articular facets of one vertebra with the superior articular facets of the vertebra inferior to it. And so when you flex or extend your spine, we're just going to get little bitty sliding movements between the articular processes. And as I mentioned earlier, you can see the disc coming out just a little bit anteriorly and then just a little bit posteriorly when you're doing flexion. And that allows you to have that smooth flexion of the spine or extension of the spine. It's the culmination. So the zygoapophyseal is between the articular facets. That's going to be a gliding joint. Whereas the intervertebral disc articulation, remember, that was an amphiarthrosis. All right, so now moving on to our pivot joints. So it's going to be, again, a uniaxial rotation around a central axis. And so the one that we looked at in this class was the proximal radioulnar joint. So here's the radius, here is the ulna, and here's the proximal radioulnar joint. And so the movement that we're having is pronation. And remember, during pronation, during pronation, the radius is going to cross over the ulna at the proximal radioulnar joint. So as you can see that happening, and that muscle right there is the supinator muscle, by the way. So that's our first pivot joint. And then our second one that we looked at was the atlantoaxial joint. So here's the atlas and here's the axis. So the atlas is just going to turn and pivot around that odontoid process, as well as the skull. So when you shake your head no, that's due to the atlantoaxial joint, a pivot joint, all held in place with that transverse ligament there. All right, our next joint is going to be the hinge joint. So this one is also uniaxial movement, but now we're going to be doing flexion and extension. Flexion, extension, hyperextension. So the first joint that we can look at that's a hinge joint is your elbow joint. So here would be flexion at the elbow joint, right? Uniaxial movement, and then here's flexion, or I guess there's some extension. Look at the olecranon of the ulna going right into the olecranon fossa of the humerus. But as you can see, hinge joint, flexion and extension. That's the elbow joint. And then same thing for the knee joint. Remember, the tibia articulates with the femur. And so you can see we're getting flexion and extension, extension, flexion. So that's going to be your hinge joint. And then also interphalangeal, I believe I put it in here. Yes, so here's your interphalangeal. So between the phalanges, not the metacarpals, just the phalanges, as you can see that there. Right? So here's one, two. So you have proximal interphalangeal joint and a distal interphalangeal joint. So proximal, distal right here. So that's a hinge joint there because you can only flex and extend those joints. And then the talocrural, so your ankle joint, again, I don't think I have a picture of this, but you can pretty much only flex and extend your ankle joint as well. And then as I said before, your mandible, your TMJ joint is a combination of a hinge joint, so hinge and gliding. All right, moving on to our next joint. So this is our first biaxial joint. A condyloid joint is the joint that allows flexion and extension and a abduction and a deduction. So the first place where we can see that is the radiocarpal joint. So your wrist joint, right? So here's flexion, right? Flexion, flexion, extension. But then also we can do an ulnar deviation or a radial deviation, right? And a radial deviation is going away from you, it's going laterally, so that's considered a abduction. And then an ulnar deviation, which is going towards your midline, would be considered a deduction. So as you can see, the wrist joint allows flexion, extension, and then a deduction and a abduction there. Also, the atlanto-occipital joint, remember that's between the atlas, so C1, and the occipital condyles of the occipital bone. So that allows you to nod your head, and it also allows a little bit of flexion at the head as well. And then I believe I put in the metacarpophalangeal joint. Yes, here's your metacarpophalangeal joint. So here are your metacarpals right in the palm of your hand, and then they articulate with the proximal phalanges. So you can do like this. So here's flexion, extension, right? So flexion, extension, but then you can also do abduction, right? Abduction, and then a deduction. So you're that's a condyloid joint, right? So you have flexion, extension, abduction, a deduction, condyloid joint, metacarpophalangeal joint. All right, so our next joint now is going to be called a saddle joint. So this joint has multi-axial movement, meaning it can do everything. So flexion and extension, abduction, a deduction, opposition, and circumduction in the thumb. So that exists at the sternoclavicular joint. So you can elevate, depress, protract, and retract your shoulder. And then also the one that we really hone in on was the first carpo-metacarpal joint. So remember, the carpal bone in this case is your trapezius, and then the first metacarpal obviously, of the thumb. So here I got a video of opposition, but you can do abduction, adduction, flexion, extension, circumduction, and then opposition, all due to that first carpometacarpal joint between the trapezium of the thumb and the metacarpal of the thumb right here. Okay, so now we get to our most mobile joint, but the least stable joint. So multi-axial again. So we're gonna be able to do flexion, extension, abduction, adduction, and then a medial and a lateral rotation as well. And then also circumduction, all at this ball and socket joint. So the two ball and socket joints that we have are obviously your glenohumeral joint and then your femoroacetabular joint or your hip joint. So I think I have, so here's extension and flexion of the humerus right at the glenohumeral joint. There's the articulation. I think, what's this one? Extension. Oh, so there's going to be your adduction, abduction, adduction, bringing it back. And then the last one that I have is a rotation. It's like a lateral rotation in this case. And then same thing goes for the hip joint. So there's flexion of the thigh, the hip, extension, flexion. And then I believe there's adductor magnus, adducting the leg, and then different muscle. But as you can see, also we get a bduction at the leg. And you can also do circumduction at the leg, just like the humerus, or just like the shoulder.
Or grinding,
Oops.
arthritis, and posture issues.
Oops.
Anxiety and stress have also.
Sorry about that. So now we're just going to look at, I just called them selected articulations. So these are just ones that we looked at in a little bit more detail. So first, the temporomandibular joint, like I said, combination of a hinge joint and a gliding joint. So here is the hinge portion, right? Your opening, that's a hinge joint. And then the gliding. So as you can see, it's a combination of those two diarthrotic joints. Okay, and so now looking at the vertebral column, also looking at the ligaments. So the anterior longitudinal ligament, it's right here in this picture. And then I got some pictures from the app. Here it is in green. It's thick. It goes all the way down inferiorly. And what this is doing, it's attaching the vertebral bodies and the intervertebral discs. So we definitely want to keep those discs intact in place in between the bodies. And that's what this anterior longitudinal ligament does. And then the posterior longitudinal ligament, I'm sorry. As you can see that it's right there in this image. And then I put it in green here. It goes all the way down. It's actually also in the vertebral foramen. It's much thinner than this anterior longitudinal ligament. It has the same function. It's attaching the posterior vertebral bodies to the discs. But since the posterior longitudinal ligament is so much thinner, you're more likely to have damage posteriorly. So, for example, a herniated disc, that's when the nucleus pulposus begins to bulge out posteriorly and it can compress your spinal nerves. I actually have a very badly herniated disc, and trust me, I can feel it compressing my nerves when I get pains through my leg. Okay, so your zygoapophyseal joint, remember that's the gliding joint. That's going to be between the superior articular facet of one vertebra and the inferior articular facet of the superior vertebra there. So that's your gliding joint, right? And then the amphiarthrosis was between the intervertebral discs and the bodies there. So just briefly going over the composition of the intervertebral discs, remember this annulus fibrosus is the outer layer of fibrocartilage. That's what makes it an amphiarthrosis, specifically a symphysis. And then this inner nucleus pulposus, it's a gelatinous consistency, mostly made up of water. Okay. All right, so now looking again at the shoulder joint, and some ligaments. So remember, it's a ball and socket joint, the most unstable. So here's your humerus, here's your scapula, and then the glenoid cavity is somewhere in here. So just going down this list, we have some ligaments, of course, that afford some more stability. So the coracoacromial ligament. So the coracoid process here of the scapula is connected to the acromion of the scapula here. So coracoacromial ligament. And then the coracohumeral ligament here, again, connecting the coracoid process of the scapula to the humerus here. This one's pretty big there. And then the acromioclavicular ligament, it's right here, acromion of the scapula to the clavicle. See, the names of the ligaments really tell you what they're connecting. Just wanted to briefly run through that. And then the labrum, this labrum here, it is in, I don't know what color this is. I guess like a periwinkle kind of. I don't know. But so the labrum, it's just going to be fibrocartilage that covers the glenoid cavity there. And as you can see, the bursa outside of the joint cavity there. Yeah. Okay, so we just went over all of those anterior ligaments. And as you can see, even though we have a lot, nothing can compare to this rotator cuff muscles, right? So we have 3 posterior rotator cuff muscles, and then anteriorly the subscapularis. But posteriorly, as you can see, the tendons of the posterior rotator cuff muscles maintain the articulation between the scapula and the humerus, and they're much, much stronger than those ligaments anteriorly. So what that means then is that damage tends to occur anteriorly, and you might have something like a shoulder drooping anteriorly, showing you have damage. All right, so then we move on to the ankle joint, also called the talocrural joint. Remember that the tibia and the fibula both articulate with the talus. And what you really need to know here is that the deltoid ligament is going to be on the medial side. So it's going to be right here, binding the tibia to the talus. And look how thick that deltoid ligament is. It rarely ever tears, so it's really strong. And so it's on the medial side. It's going to prevent too much inversion of the foot. And then if we look at the lateral side, though, the lateral ligament here that binds the fibula to the talus, the fibula is much thinner, and so is the lateral ligament. And so since the lateral ligament is so much thinner, it's much more prone to sprains and tears. So make sure you know that the deltoid ligament is medial. And I think that should kind of make sense because the tibia is that thick bone. The tibia is the one that really, really connects with the talus, really forms that talocrural joint. Like I said earlier, the fibula, it does articulate with the talus, but just laterally, and it's really just there for some extra support and stability. Okay, so now we get to the knee joint, another hinge joint, right? The tibiofemoral joint, because remember, only the tibia articulates with the femur via the lateral and medial condyles. So just going down the list here, starting off with the ACL, your anterior cruciate ligament. So it's going to run, posteriorly here, as you can see that, and then anteriorly to the to the tibia, I'm so sorry. There's that. And then it kind of forms like an X with the PCL, the posterior cruciate ligament here. Much easier to be seen there. So ACL, PCL, ACL, PCL. And then the medial collateral ligament, it's also called the tibial collateral ligament here. And that's just going to run from the femur to the tibia. And then we get something similar on the other side, the fibular or the lateral collateral ligament. It's going to be running from the femur to the fibula. And then finally the menisci. So these are going to be 2 fibrocartilage pads. So you're going to have a lateral meniscus on the fibula side and then a medial meniscus on the tibia side. So they're just going to be adding extra cushioning between the tibia and the femur here. All right, and so that brings us to, I believe it's our last slide, what's known as the unhappy triad. So if you have a lateral blow to the knee here, that can cause you to knock out the medial collateral ligament. So remember, that's your tibial. Look at that, just came right, just torn. Your medial meniscus, as you can see, that's torn here, and then also the ACL. So that's what the unhappy triad is. All right, so that was a summary of their articulations. I hope that made things clear. Happy studying, stay safe out there, and have a good night.